Session, 5 interesting cases. I'm going to start in maybe 1 more minute just to give any latecomers a chance to join. As we go through the session, feel free to drop your questions into the chat box, which I have open here, and we'll keep a close eye on all the way through. Let's get started. My name is Ben Lovell. I'm a consultant in acute medicine working in London. And this session is called 5 Interesting Cases. And the purpose of this was a little bit different, I think, to the normal teaching that you get. This is just stories, patients that I've met in my career that I found interesting and I thought might be interesting to you as well. Some of these conditions we'll talk about are rare and unusual and not things that you'll see in your everyday practice, but maybe some others have more relevance to you. And it's fun, I think, just to be presented with a diagnostic puzzle sometimes and guess and try and work out the responses. So that's what today is all about. I work partially in a unit called ambulatory care, or AECU, Ambulatory Emergency Care Unit. And the purpose of ambulatory care is for same-day diagnosis and treatment of health problems. So we get referrals from GPs in the community who have a patient who probably needs bloods and maybe some scans or maybe some other tests done today and a diagnosis and a treatment starting today. And we have access to those resources, which most GPs in the community don't. So let's kick off with the first case, and this is non-resolving breathlessness. So here's a presentation, so have a look at this. This was the referral I got from a GP in the community, and they said, "Dear Ambulatory Emergency Care Unit, I'll be grateful if you could see this 71-year-old gentleman with known COPD who's not responding to oral antibiotics. He has had 5 days of prednisolone, 30 milligrams, 5 days of oral amoxicillin, and then 5 days of doxycycline. He's still very breathless and wheezy. And I would like bloods and a chest x-ray, please." And then the patient came to see me. And I met the patient. I discovered that he had COPD for 17 years. He'd stopped smoking 30 years ago. He usually uses the salbutamol inhaler once a week, but is now using it constantly. And his past medical history was significant for stage 2 chronic kidney disease due to hypertension. He also had gout and had a melanoma excised in 1997. And medication-wise, he was taking amlodipine, 10 milligrams, paracetamol, simvastatin, 40 milligrams, salbutamol PRN, and he was on a LABA-LAMA combination inhaler called Onoro. So a long-acting beta agonist and a long-acting muscarinic agonist combination inhaler for a COPD. And on examination, his respiratory rate was elevated at 26. He had a mild wheeze on his chest, no crackles. His saturations were good. They were 97% on air, and he had a very severe dry cough that he was coughing all the way through the consultation. Clinically, he looked euvolemic, and his vital signs, including his heart rate and his blood pressure, were within normal limits. So I did a chest x-ray, and it looked like this. So please do take a second to have a look at that chest x-ray. I'll just move this out the way so you can see it properly. And I did some blood tests, and here are the results of the blood test. A lot of them to see here, but there's CRP at the top, sodium, potassium, urea, and creatinine. I'll tell you that this creatinine of 148 was normal for him and his chronic kidney disease. Here's the full blood count, hemoglobin's here, MCV's here, platelets here, and then the white count, differential count is down the bottom here. So I'll give you a second to have a look at that. What next? So just if anyone feels brave enough or chatty enough, if you want to write something in the chat box about what steps you would take next. We've got a gentleman here with a non-resolving exacerbation of his COPD, and he's still wheezy despite 5 days of pred and despite 2 courses of oral antibiotics with blood tests as you've seen, their chest x-ray as you've seen. What would you do if this was you? Discharge them home. More antibiotics. Okay, what further tests would you like, Dr. Reynolds? What kind of CT scan and what scan are you looking for? A CT scan of the head, chest, hip, leg. I'll get you a high-res CT, so an HRCT of the lungs. Okay, looking for a CTPA. So a high-res CT is a really good scan for looking at the parenchyma of the lungs. So I assume if you wanted a high-res CT, you're thinking about interstitial lung disease, fibrosis, pulmonary fibrosis, some description. Could be. Rather acute onset, though, for it. Just 2 weeks, I think, of breathlessness. Could do. Okay, so has he had COVID? No, he hasn't. And he tested COVID negatively throughout his journey. That's a good point. I met this patient before COVID existed, actually. So what I actually did was I thought I'd give him another go with some more steroids. He'd had 5 days of 30. Sometimes people with very reactive airways disease they do need high doses of steroids for a bit longer. Your suggestion of a D-dimer to look for a PE, it's possible. It would be not impossible, but it would be unusual for a PE, an acute PE, to cause bronchospasm, but no hypoxia and no chest pain. So my pre-test probability is quite low already if I wanted to go down the D-dimer road. So what I did was I gave some more steroids. I gave 40 milligrams of Pred, and I said, take these for another 4 or 5 days and come back to see me. And he did, and he was still very wheezy. And what he said to me was that he was so much worse with his wheezing and his breathlessness and his chest tightness in the morning when he woke up, and his cough was absolutely dreadful during the night, and he couldn't sleep. Does that mean anything to anyone? So heart failure might give you paroxysm PND, and that would make you wake up breathlessness in the night. Any other conditions that give you breathing, wheeziness, worse in the morning and cough overnight? I started to wonder, because I'd seen this before in a couple of patients, whether this chap had COPD alone or whether had COPD and something else. I did spirometry in the clinic, and it showed an obstructive picture, as expected with COPD, with a handheld spirometer device, which didn't really take me forward anywhere. And so what I asked him to do was to go home and keep a peak flow diary. I showed him how it looked and said, could you come back in a few days and just show me what results you're getting? Could you do your peak flow maybe 3 times a day? I showed him how to do it. And could you maybe do it before and after you take your salbutamol inhaler? And this is what he brought back to me after a week. So Kathleen has sort of started thinking in a certain direction on the chat, but here is someone who's got way worse obstruction in the morning at 6 a.m. when he woke up, which improved throughout the day. And if we say that the red are the ones he did after he'd taken an inhaler, which he didn't do all the time, but he did do, there's a couple of interesting features on this peak flow chart. Number one is diurnal variation in his peak flows, his best effort. Worse in the morning, much better. It doubled over the course of the day. And also, it looks like there was pre and post bronchodilator reversibility. Reversibility and diurnal variation on peak flow point strongly away from COPD, which is a non-reversible obstructive picture and points more towards asthma. And I started to think, has this chap got COPD at all? Or has he actually got asthma? Or does he have a bit of both? I sent him for some repeat lung function tests and for FeNO. FeNO is fractured expiratory nitric oxide in your breath. It's now a test which is advised here in the UK for helping you make a diagnosis of asthma. because people with eosinophilic bronchial inflammation excrete NO, nitric oxide, in their breath. There's no one test, as you know, that diagnoses asthma, but there's lots of clues which can point towards asthma. And his pheno showed he had elevated levels of nitric oxide in his expired breath, and that, plus that peak flow chart, plus the fact that he wasn't really responding to good going COPD therapy, made me change his diagnosis. And I actually diagnosed him with late onset asthma. And you're going to say, well, so what? And I'll tell you what. But a bit of background in adult onset or late onset asthma is actually more common than you think. 40% of patients over the age of 60 who have asthma actually got their first symptoms after they were 40. And it's not as atopic as childhood asthma is. Childhood asthma is often associated with a good-going eosinophilia, with allergies, with hay fever, with bad eczema, but you don't get then adult onset asthma. Factors that tend to predict late onset asthma: if you're a smoker, if you're a snorer, if you have rhinitis symptoms, or chronic sinus symptoms, and if you're overweight. Can you see how tricky it is to actually make a diagnosis of late onset asthma? Because if someone came to you with breathlessness and wheeze and exacerbations who was a smoker, you're going to say COPD, especially if you do spirometry and they have an obstructive picture. If someone comes to you with breathlessness and they're a snorer and they have obesity, you're going to start thinking of obstructive sleep apnea. If someone comes with rhinitis symptoms or chronic sinus symptoms, you're going to start thinking of postnasal drip, maybe aggravating a chronic cough. So it's quite a difficult diagnosis to make. And I find that giving patients the peak flow diary for them to keep for a few days is absolutely key for sort of working past your initial assumption of what you think they might have and getting to what's going on. 50% of late onset asthma cases seem to be triggered by a really bad respiratory tract infection. So if you have a patient who had a really bad chest infection and they just never shook it off, and ever since then they've been breathless and wheezy and coughing overnight, think about adult onset asthma. And we have much less data about efficient treatment in elderly asthmatics as we do in childhood asthmatics. It's very poorly diagnosed. When elderly people become breathless, it often gets assumed to be a symptom of their age, or ascribed to other illnesses such as heart failure, for example. And we do know that people's FEV1 over FVC, that ratio does go down with aging. So it often gets misattributed to other conditions, aging conditions. Now, here's the big question. So what? Ben, you've been very clever. You've changed your diagnosis. Have you actually made an impact to your patient? Well, there are some important things to take into consideration. People with asthma have a much higher mortality when they have bad exacerbations than people with COPD. That's one thing to be aware of. And when people with asthma are ill with chest infections or exacerbations, we have different safety parameters. You know about your COPD patients. If they are retainers of CO2, we take that on board and we say, okay, this is a retainer. Maybe their target sats can be 88 to 92% rather than 94 to 98 when they're unwell or when they're in hospital. We would never tolerate a rise or retention CO2 in an asthmatic. It's a sign of impending respiratory failure. We would never tolerate sats of 88 to 92 in an asthmatic having exacerbation, because that's someone who's dangling on the edge of needing ventilation. So when they're sick, asthmatics and COPD people, you need to know what phenotype you're dealing with, and also need appropriate therapy. You remember this chap here was taking a LABA/LAMA inhaler. Now, that's fine for COPD. It's not fine for asthma. What treatment should he be on for his asthma? Fine, a long-acting beta agonist, but if we look at the stepwise approach to managing asthma, it's an inhaled corticosteroid, and he wasn't taking one. So he needed to be on a different inhaler technique. So that's important. This is why he is having symptoms, why he's not getting control of his symptoms. Also, people who have asthma, they need to have asthma education. They need to know when they're sick. They need to know the red flags or when they need to get medical attention. All asthmatics really should have a PAP, which is a personal asthma plan, asthma plan, which is what peak flow they should be doing at home, tells them when to call the doctor. For example, someone's personal asthma plan should be, if my normal peak flow is 460, if my peak flow hits 300, I should see my GP. If my peak flow hits 200, I should come to hospital. Everyone should have this. It's part of keeping asthmatics safe. And also, we need to make sure that they're using the right inhaler technique and the right adjuncts. In the UK, it's now advised that anyone taking an inhaler should have a spacer, an aero chamber to take it with, you know, that long, thin one, because the amount that you get into your lungs for simply taking an inhaler or on its own is actually very low. There was a big study done a while ago about elderly patients who use inhalers. They looked at many of them and they found that their inhaler technique was dreadful. 38% did an insufficient in-breath before they're doing it. 34% did not tilt their head back properly, were just spraying their tongue. 25% had a complete discoordination between the pressing and the inhalating, so it's more like a that sort of thing. And they estimated that only 10 to 30% of medication actually reached their lungs. So these people really need that either a big volumatic spacer or that nice little aero chamber so they can squeeze, and then just breathe it in. And they get much more effective use. So the other thing that's important when you're differentiating between your COPD patients and your asthmatic patients is sometimes if someone has a very bad COPD, they might get nebulizers at home or even home oxygen if their breathing was bad. We would never give home oxygen to an asthmatic. That implies really badly treated asthma. And it's not considered good practice to give home nebulizers to people with asthma. And the reason for that is if an asthmatic is sick enough to need a nebulizer, that means they're sick enough to be in hospital. The danger is people with asthma staying at home, taking nebulizer after nebulizer when they have a very bad exacerbation until eventually they go blue and stop breathing and they die and they don't get to hospital in time. So needing a nebulizer is considered a trigger for inpatient stay. And that's why it's important to know whether you're treating someone with asthma or with COPD. So that's my first case. That was your taster. How was that? Any questions about that case? If not, I'll crack on with the next one. Apologies if there's some ambient noise in here. I'm in a shared space. So the next case I want to tell you about is a case of a headache that was referred to me by a GP. Here was the referral. Dear ambulatory care, this 26-year-old woman reports severe right-sided headache, typical of her usual migraine, but not improving. And now she has double vision. I don't know if this is migraine or another intracranial pathology. I'd be grateful for your assistance. So I met the patient. She's confirmed that she does have a diagnosis of migraines. And her usual migraine phenotype is severe right-sided side lobe headache with a little bit of tearing of the eye. She doesn't get photophobia or phonophobia, but she's very sensitive to taste and smells, gets very nauseated. Her migraines will usually last a few days and then go away. However, this headache she has now, she's on day 4, which is longer than any migraines last before, and she's also on day 2 of having double vision. No other neurological impairment that she's noticed. And on further questioning, she says the same thing happened 3 weeks ago, severe headache and double vision, but it's self-resolved after 2 days, and she didn't actually seek any medical attention at the time. So this is her second episode. Her past medical history, she had a previous diagnosis of anxiety. She didn't take any regular medication. She drank alcohol 3 or 4 times a week, but did not exceed 20 units in a week. She did not smoke. She did not take any other kind of recreational drugs. She worked as a dancer. And on examination, I could see that she had a mild right-sided ptosis. Her pupils were equal and reactive, with no relative afferent pupillary defect and no INO. She reported diplopia on right lateral gaze, and she says the objects were split vertically, one on top of the other. There were no other neurological defects in either cranial nerve examination or examination of her arms or her legs. What do you guys think? What could be going on here? Any thoughts? Could it be a migraine? Is it a usual migraine? Is there something else at play? Ooh, okay, let's have a look. Intracranial pathology. So Dr. Al-Husseini wants to image the brain, which I think is a very good idea. Multiple sclerosis, that's an interesting idea. Demyelination of your central nervous system shouldn't cause pain in itself because that part of your body is insensate. However, if she had optic neuritis, that would be extremely painful. But optic neuritis usually presents with vision loss, so a second cranial nerve loss, rather than the extraocular muscle paresis, which she seems to have. I guess you could say that if she had multiple sclerosis leading to a complex ophthalmoplegia or a lateral rectus problem, then that would cause a tension headache to the strain of double vision. So you can make it make sense that way. And you want to do a CT scan. Okay. So what did I do? She got bloods because everyone gets bloods and they were all normal. We even did Lyme serology. We did an HIV test and we did all of the autoantibodies looking for any cause of a mononeuritis which might have affected. At that point, because she had double vision on right lateral gaze, I was looking for a cause of a right sixth nerve palsy. The unusual thing is that when she said she looked to the right, the images were vertically split. Because of course, if you had a sixth nerve palsy, the images would be horizontally split, one next to each other. Don't know if that rings any bells for anyone, but I'll leave that there for now. And she had a CT head. She actually had an MRI head. I work in a big central London hospital. We have an MRI scanner. She had an MRI head, which was normal, a plain MRI done without contrast. She had a lumbar puncture. This didn't all happen on the same day. We're not that good. But over a couple of days, we had a lumbar puncture because we were thinking, does she have MS? Does she have any kind of inflammation? And the lumbar puncture was completely normal, as was the MRI. And I asked for a neurologist to come, and the neurologist came and reviewed it and said, in fact, this patient has a partial third nerve palsy, a fourth nerve palsy, and a sixth nerve palsy. Now, the fourth nerve palsy, the trochlear nerve palsy, that explains the mystery of why she had vertical splitting rather than horizontal splitting when she had diplopia. Because if your trochlear nerve is affected, your fourth cranial nerve, then you have difficulty moving your eye in the up and down direction, and that's why you sometimes get that vertical splitting. But in fact, she's got a complex ophthalmoplegia. She's got 3, 4, and 6 nerve problems. So Kathleen's wondering about benign intracranial hypertension. Just a little point. Benign intracranial hypertension has changed its name. It's now called idiopathic intracranial hypertension. Why? Because to the patients, it's not very benign. It doesn't feel benign to have a shunt put in or to have optic nerve defenestration or to be put on acetazolamide and get terrible peripheral neuropathy. So we call it idiopathic intracranial hypertension. And that does affect people, young women, especially young women with a high BMI. They usually get a global headache though, because of the raised intracranial pressure rather than the right-sided. And when you get raised intracranial pressure, you can sometimes get false localizing signs. That usually does affect the 6. Unusual to affect 3 and 4 as well. Can anyone remember from medical school where nerves 3, 4, and 6 all touch each other, or where they think the lesion might be? Digging deep now. Don't worry if not. Also, Kathleen, if she had benign intracranial hypertension, she would have had elevated opening pressure on the LP. I didn't specifically say she didn't, but she didn't. So she had painful ophthalmoplegia. So we were throwing around the potential diagnosis at the time. Tolosa-Hunt syndrome. Anyone ever heard of this? It is granulomatous inflammation of the superior orbital fissure. Do you remember the superior orbital fissure during your anatomy, your cranial anatomy? One of the holes in your skull. What goes through the superior orbital fissure? The third nerve, the fourth nerve, and the sixth nerve. So the reason we were thinking Tolosa-Hunt is a very, very rare syndrome. But we were wondering, would that explain why she had those 3 nerves together? Also, the first branch of the trigeminal nerve, 5-1, that goes through that hole as well, and that was unaffected. So we were throwing that around as a potential diagnosis. Diabetic ocular neuropathy, well, possibly, but she's not diabetic, but we did an HbA1c just in case, but she wasn't. And a mass lesion, but she'd had the MRI scan, which had ruled that out. So we were a bit stuck in considering all the when we finally worked out the differentials, we thought, could it be migraine? Evidence for it being a migraine, it feels like a usual migraine, the right-sided pain. But what went against the migraine is why she got those 3 cranial nerve palsies. We thought about TAC, a trigeminal autonomic cephalalgia headache, like cluster headache. That would explain why she had that sort of ptosis and tearing of the eye, but it doesn't. The phenotype wasn't quite right. Why was it 4 days of constant pain? Why did she have cranial nerve palsy? And then Tolosa-Hunt syndrome. Clinically, it made sense, but on the MRI scan, we didn't see any inflammation or granulomatous tissue being deposited around the back of the eye or around the superior fissure. So I wasn't very happy with that either. Anyone got any other ideas you might have missed, or what could be going on with this diagnosis? And if you don't have any ideas, don't worry, because I was stuck at the time as well. I'll let you know what it was. She had a condition called ARPON. ARPON. What is ARPON? Recurrent painful ocular neuropathy. And you probably haven't heard of it before, but maybe you've heard of it by its old name. Its old name was ophthalmoplegic migraine. A migraine which caused ophthalmoplegia. It's a very rare condition, and it's a very rare cause of painful ophthalmoplegia. So if you do meet a patient who has got that ophthalmoplegia and they've got a headache, it's something to think about. Why did they change its name? They changed its name because it was decided that it actually wasn't actually a migraine spectrum disorder. It's a neuropathy, a cranial neuropathy. And the reason they decided that is because when you have an MRI with contrast, you can see inflammation of those individual cranial nerves, which you should never see on a migraine. It responds to steroids, which migraines do as well. But it's like any other kind of neuropathy or mononeuropathy you might have in your body. That's why they changed it. This is contentious, and not everyone is on board with this being reclassified. And in fact, we were so interested by this case, we wrote it up and we published it as a case report. And as you can see here, what we said was this case adds to the debate whether the cause of ARPON is truly neuropathic or migrainous. For my money, I would say that it is a neuropathy. It is ARPON rather than a migraine, because why are you seeing inflammation on the MRI, which you do not see in a migraine? The treatment is steroids. So she was given high-dose steroids for several weeks with a complete resolution of her symptoms. But now I'm sensitized to it and I might see it again. So if you do see a patient with any kind of ophthalmoplegia and a severe headache, this is something for you to think about. And then you know you have a treatment option, which is steroids, because it's a steroid responsive condition. Any questions, then please do put it in the chat. Otherwise, I'm going to keep marching forward. Unexplained breathlessness, case number 3. Dear Ambulatory Emergency Care Unit, this 52-year-old woman has presented to me today with shortness of breath, which has come on over 24 hours. Her chest is clear. She has no chest pain. She is tachycardic at 110 with a normal blood pressure. I'm worried she might have a PE. Okay, so I met the patient. She tells me she's been short of breath for a day. She feels lethargic. She feels weak, a bit clammy, a bit sweaty. No cough. No sputum, no symptoms of a chest infection that goes with this shortness of breath. No chest pain, either central cardiac chest pain nor pleuritic chest pain. No recent fever, no recent infective symptoms, no recent COVID. No previous respiratory diagnosis, i.e. she did not have asthma or COPD or anything like that. And her past medical history is that she had type 2 diabetes. She had pneumonia in the past, for which she was very sick and was in ITU and had to be intubated. She had hypertension and she had varicose veins, and she also had a diagnosis of anxiety and depression. And here are her medications: aspirin 75, citalopram, an SSRI, canagliflozin, an SGLT inhibitor for type 2 diabetes, lansoprazole, 30 milligrams for acid, and ferrous fumarate for iron replacement. So I examined this patient, and she was short of breath. Her respiratory rate was obviously elevated at rest. It was 24 breaths a minute. Her saturations were excellent, 100% on room air. Her heart rate was slightly elevated at 110. Blood pressure was low end of normal. She looked a bit dehydrated. Her chest was completely clear. There were no signs of edema or any signs of heart failure, such as an elevated JVP or crackles on the chest. And a cardiovascular exam was completely normal as well. I did a chest x-ray and it looks like this. Just to show you that for a moment. And I did some bloods. Her FBC was normal. Her sodium's normal, her potassium's normal. Her urea is slightly elevated at 13.1, but her creatinine is normal. Her CRP is normal. Her liver function test and her clotting is normal, and her D-dimer was normal. Did an ECG, showed sinus tachycardia with no ischemic changes, no evidence of any heart block. You did a VBG, a venous blood gas, part of our routine assessment when we see people in ambulatory emergency care for two reasons. One, it's a point of care blood test, so we have the results within minutes rather than the FBC, which takes an hour to come back. And second of all, it gives us the lactate, which we don't get on venous bloods as well. Anyway, here it is. So her pH is low. Her CO2 is low. Her PO2 is low, but this is a venous gas, so your PO2 will be low. So that's okay. Her bicarb is low. Chloride's okay. Basic cess is low. What on earth is going on with this patient? She looks clammy and unwell. She's slightly tachycardic. She looks dry. She feels short of breath. She's breathing like this. And her metabolic analysis for blood shows that she's lowered her CO2 and she's acidotic. Has anyone seen this case before or read about cases before? Yeah. So there's an acidosis. Is it a respiratory or a metabolic acidosis? Well, the CO2 is low rather than high. And yeah, her bicarb and her basis are low. So a metabolic acidosis. Due to what? We can't blame it on the lactate, that's low. We can't blame it on the renal function because that was normal. What else can cause a metabolic acidosis? Well, the acids can be generated in the body. So there's ketoacidosis. So look at her glucose, her capillary glucose, 6.1. How can she have DKA without the hyperglycemia? Okay. We tested her urinary ketones. They were unrecordably high. We then did her serum ketones and they were 5.1 and they should be less than 0.6. So she has severe ketoacidosis, but with normal blood sugars. And here we go, because Sasibimon has made the diagnosis in the chat. She has euglycemic ketoacidosis due to her medication, her SGLT2. This used to be a rare phenomenon, and now it is increasingly recognized. And I've seen it a few times in my practice. She was taking canagliflozin. Remember from her medication history. What is canagliflozin? It's an SGLT2 inhibitor. It promotes patients to pee out glucose. It induces glucoseuria, and it normalizes your serum glucose this way. So it's a very novel way of acting on your diabetes, and they're getting more and more of them around. it is actually empagliflozin in particular, which one of them has been discovered to be almost a miracle drug in terms of diabetes and cardiovascular health. It reduces your the incidence of heart failure and heart-related catastrophes such as MI when you take it, even if you're not diabetic, which is absolutely astonishing. But it's being more and more used now in people with type 2 diabetes. But it has a rare but well-known and very curious side effect, which it promotes euglycemic diabetic ketoacidosis. And it's difficult to spot because their serum glucose is normal, but their ketones are through the roof and they have a profound acidosis. And in my patient, her acidosis manifested in a respiratory compensation. So she was trying to compensate for the metabolic acidosis by hyperventilating and blowing off CO2. And that is what caused her actual index presentation, the breathlessness. As I say, it's a known complication of these new drugs. The mechanism is not very clear. It's theorized that the sudden drop in your serum glucose causes a concomitant drop in your insulin production, which overshoots the glucose. And it also, when you're taking SGLT2, it increases your kidneys to reabsorb ketones. So sometimes you'll even test their urinary ketones and they will be normal. So they're unreliable. You need to do their capillary ketones to actually get a clear measure of what their ketosis state is. What is the treatment? Stop the drug, the SGLT2, and also treat them with an insulin dextrose infusion, which forces down the ketones and maintains euglycemia. So this is something you will start seeing these drugs around because they have an excellent profile in terms of both diabetic health and heart health. But this is a side effect which we all need to be aware of, which can be tricky to pick up, but is increasingly recognized. Here's where they act in the kidney. If you think about all your other diabetic medications, your sulfonylureas, your biguanides, the new DLP4s, they all act in the pancreas. They all act on insulin production or sensitivity to insulin. These are the only ones that act in the kidney, and they promote glucosuria. So they're very effective monotherapy. They're very effective add-on therapy. As I say, they help with weight loss, they help with reducing blood pressure, and empagliflozin has been associated with actually improvements in cardiovascular health as well, and slowing the progression of CKD in people with type 2 diabetes. But this is a known side effect of the drug. So well done to anyone who got that right. Moving on to case number 4. This is a case of back pain. Dear ambulatory care, this is a 76-year-old female who's woken up with severe back pain in the right posterior ribs, so the thoracic spine. There's also some concern that she's had some hemoptysis, although this was not witnessed by me. She's 2 weeks post-op and she's worried she might have a PE, pulmonary embolism. So more information from the patient. She's 2 weeks after having a varicose vein removed from her legs, and she woke up with severe right-sided thoracic back pain yesterday. But the pain is now completely gone. Not short of breath, now was never short of breath at the time. And asking about this hemoptysis, she said she may have coughed up some blood this morning, but she wasn't sure because she was eating prunes at the time, and maybe it was just dark prune stained sputum. So that wasn't a very clear story. No chest pain. Past medical history, she was actually really fit and well for her age. She took calcium supplementation, but no other medications. She never smoked. She didn't drink any alcohol, and she was completely independent and occasionally was a carer for a grandchild. And on examination, her heart rate was 76 and regular. Blood pressure was excellent at 134/79. She was warm, well perfused. Her respiratory rate was 18 breaths a minute, and her saturations were 98%. And I got her up and I walked her all around the clinic quite a few times with the SATS probe on her finger, and she didn't desaturate once, which is a test I sometimes do when I'm considering a pulmonary embolism in a patient. Do they desaturate on mobilization? But she did not. I had a really good prod with my hands on her chest wall and on her back, and I couldn't elicit any tenderness, and I couldn't trigger the pain that she'd had yesterday, which prompted this admission. She had good range of motion and the thoracic spine. Her chest was completely clear. I looked at her legs where the veins had been stripped 2 weeks ago. They had dressings on, and the legs were a little swollen, as you would expect in someone who just had varicose vein removal surgery, and they had dressings on, but they were not leaking. They weren't unduly painful. And here was her chest ECG rather, which showed her to have normal sinus rhythm, no bundle branch blocks, no evidence of conduction defects, and no severe ischemic changes that made me worried about an MI or anything. And I did a chest X-ray, and as you can see here, it was completely clear. The blood results came back showing a sodium of 139, potassium normal, urea is normal, creatinine is normal. CRP 79, that's not normal. The CRP should be less than 6. White cells, neutrophils, and platelets are normal. And I wonder whether the CRP was 79 raised because she was 2 weeks post-op. And of course, after operation, you will get a rise in your CRP. I wasn't sure. I couldn't find any symptoms of infection anywhere in here, which would explain that. So, and she looked really well. And I think that's worth saying. She looked really well. She felt well. She said, well, I'm here because my GP told me to come, but my symptoms have all improved now and I don't really know why I'm here. And maybe I should just go home. And I was a bit stuck. One thing I couldn't explain was the CRP. And another thing rather, that I was told was that her D-dimer was 1,860. Now, your D-dimer in my hospital should be less than 550. So this is an elevated D-dimer, but it's an elevated D-dimer in the context of someone who's 2 weeks post-op. It's a fibrin degradation product. Has she been recently making blood clots? Of course she has. They've just cut her legs open and removed her veins, and she's healing. So of course she's got elevated D-dimer level. And on its own, it didn't really, to me, diagnose anything. So what would you do? What would you do? Posterior thoracic, severe pain in the ribs yesterday, now resolved. Not short of breath, not hypoxic. 2 week post-op with an elevated D-dimer and an elevated CRP. Would you discharge her? Would you do any more tests? Where does your sort of risk balance lie? So Linda suggested the Wells score, which is absolutely brilliant. I'm going to talk about the Wells score in a minute. And I did work out her Wells score, and it was elevated because of her recent surgery and her age. I can't remember what it was, but it was high. What would you do then? So Saja definitely wants to do a CTPA. Do you think you've got enough evidence here to do a CTPA in someone who's now asymptomatic? Obviously, you think yes. This was my question. This is what I was struggling with. Do I put a cannula in her, arrange for a CTPA, and then chase the result, make her wait a few hours, expose her to the radiation, or am I overreacting? Anyone else feel brave enough to say what they would do? They're all on the fence like I was. So what I decided to do, I decided on that particular day, and on that mood I was in, I was feeling quite risk averse, and I did do a CTPA. Here is the scan, the slice. Can you see the problem here? Here's the report. There are extensive right-sided PEs involving the distal right main pulmonary artery, right down to the lower lobe segmental level and subsegmental levels. There's also some in the right middle pulmonary artery. There's subpleural, peripheral, and parenchymal changes within the apical segment of the right lower lobe, which look like a developing pulmonary infarct, and no signs of right heart strain. So this was quite a shock to me, because as I said, the patient's symptoms had gone away. She was well, and I could have theoretically explained away the blood test abnormalities by her recent surgery, which I almost nearly did, and I almost missed the diagnosis. And in fact, not only has she got clots, she's got extensive clots. She's infarcted her lung, which would explain the pain she had yesterday. So what do I do next with this patient? Do I admit her to hospital? Do I send her home? Or what do I do? Linda previously asked me what the Wells score was. Now, where did she score? Evident DVT. Both her legs were swollen due to surgery and had dressings on. So that was not an easy question for me to answer. Whoops, and I answered no. Alternative diagnosis less likely than a PE. That's really clumsily phrased in my experience. But basically, do I give 3 points for saying it probably is a PE? I don't know if I did. Heart rate more than 100? No. Surgery in 4 weeks, 1.5? Yes. Personal history of VTE? No. Hemoptysis? Maybe, maybe not. Malignancy? No. So her score could have either been 1.5, or if I was feeling generous, I could have given her 3 points over here, 3 points over here, and maybe a point over here. We could have taken up to 8.5. So the Wells score is notoriously vulnerable to bias and subjectivity. We do know that if someone has a D-dimer and a Wells score, this actually can guide us towards working out whether to scan them or not. If we use the cutoff score of 4, and that means above 4 is a high Wells score and below 4 is a low score. If someone has a low Wells score and a negative D-dimer, we know that their risk of having any kind of clot's about 1.4%. And in fact, we don't really feel compelled to go ahead and scan them. We can stop at that point. If someone's got a low Wells score but a high D-dimer, about 16.7% of that population will have a clot. And therefore, we would use this particular population, we would scan them, looking for clots. If someone has a high Wells score, more than 4, you don't need to do a D-dimer. We know that 40% of people with a Wells score of 4 or more actually have a PE, and therefore a D-dimer is not needed, and you can go straight to the scan. And the D-dimer can actually put you off and can confuse matters in a high Wells score patient. The negative predictive value of a D-dimer falls the higher your Wells score is. So a negative D-dimer in the context of someone with a high Wells score of 4 isn't clinically useful. It doesn't say they haven't got a clot. Sometimes you can use PERC. I don't know if any of you have ever heard of PERC or used PERC before. This is a new scoring metric sometimes you can use in acute medicine or an ED to work out the likelihood of someone having a PE based on their clinical features. And you get 1 point for each of these criteria. You're over 50, you've already got 1 point. Heart rate, the saturations, whether there's leg swelling or there's any hemoptysis, recent surgery, hormonal use, or previous VTE. And the PERC really is a rule out score. If you score 1 point or more, you cannot rule out a PE, and you have to use something else. Wells score, D-dimer scanning. But a score of 0 in your PERC score means that you can effectively rule out a PE, or at least make the likelihood of a PE less than 2%, which is as good as a rule out, really. So PERC is a useful tool sometimes. Management. So I asked you what you guys would do, and some of you said you want to admit the patient. Well, when you're working out whether or not to admit a patient, I like to risk stratify patients with PEs using the PESI score, the PE Severity Index, and it gives you different points. You don't have to remember all this. You can look it up on MedCalcs online and work out someone's score. But it works out a severity score based on these features: age, sex, whether they've got cancer, heart failure, lung disease, heart, blah, 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 blah. And then it risk stratifies them into a class. Class 1 has got the lowest 30-day mortality. Class 5 is the highest. And this sort of helps me decide what I want to do with my patients. So if someone scores enough points to get into class 1 or class 2, I usually ambulate these patients, i.e. I send them home with the anticoagulation. I organize follow-up in the anticoagulation clinic. And obviously we do a bit of thinking about, okay, we've diagnosed PE. Why did you have a PE? Sometimes there's a clear precipitant, such as the recent surgery in my case, but if it's not, then we have to do a bit of thinking, maybe wondering about occult malignancy in older patients. If someone is class 3, it's up to you whether you want to admit them to hospital or you think they're safe at home. But obviously class 4 or 5, these are usually the patients who are very tachycardic, hypoxic, unwell, and they have to come into hospital for oxygen and a bit of cardiac monitoring, a bit of observation, and as well as being started on anticoagulation. So in my case, her PESI score came out putting her in class 1. low risk, low third-stage mortality. So I sent her home with anticoagulation, which in my hospital we use apixaban, which is a DOAC. Final thoughts about PE. The radiographic clot burden does not correlate with mortality. So it doesn't matter. Remember, in my case, she has so many clots everywhere. That doesn't actually say you're going to do worse in the long term. Echocardiogram is a useful test if they have hemodynamic instability, i.e. a low blood pressure. But if the patient's stable, it doesn't really add much to the initial management or assessment of the patient. It often shows right heart strain, but that's okay. That's expected in someone who has a PE. What is more useful is an echo a few months down the line, 3 months or 6 months later, just to make sure they don't have any long-standing pulmonary hypertension or right-sided heart failure. So that's something I do a bit later rather than sooner in very well patients. Okay, I'm going to do my last case, which is a case of facial numbness. Dear ambulatory care, this is a 51-year-old man with left facial numbness. He was a thrombolysis call. This means that he was initially assessed to be a risk for stroke. They thought he had an acute stroke. But on assessment, the numbness came on slowly over several days rather than suddenly. Therefore, clinically, it is not a stroke. He needs an MRI scan, which we have requested for you, signed the stroke team. So it's actually the stroke team who sent this patient to me to be assessed. Okay, so insidious or a subacute onset of left facial numbness. So I met the patient. He says over 9 days, he had evolving left facial sensory symptoms. Initially started as paresthesia on his left upper lip, but then it spread to involve his left cheek, the left side of his nose, the left side of his forehead, the inside of his mouth on the left, the inside of his cheek. And now it has developed from numbness to a burning, tingling, electrical sensation, which is very unpleasant. He's usually fit and well. He was a paramedic, actually. He never smoked. He occasionally drank alcohol. And he's never had this before. And on examination, he clearly had altered sensation to the left side of his face to all modalities, to sharp, soft, temperature. And that included his left face. In fact, it went up to his scalp, up to the to his crown. It spared his left ear, which had normal sensation. It involved the left side of his tongue. He couldn't, that was abnormal. And the left inner cheek and his gums on each side. His acuity and his visual fields were completely normal. His cranial nerves were otherwise normal. He had no ophthalmoplegia, normal cranial nerves 11 and 12. He had an absent corneal reflex. So when I touched his eye with cotton, he didn't blink. He had no sensation there on his eye as well. So that was also affected. And his limb examination neurologically was fine. All of his bloods was normal. His ECG was normal. What could be going on with this guy? Please do have a think and let me know if you've got any ideas, bright ideas, because at this point I was very intrigued and I had a couple of ideas in mind. So, okay, we're talking about what kind of cranial nerve. So he's got impaired sensation to definitely 5, V1, 2, 3. So forehead, maxillary, and mandibular. So that's 5. Has he got impairment to 7, cranial nerve 7? Cranial nerve 7 will be movement, paralysis. So we'd have a facial paralysis. He didn't have that. So why 7? Okay. So we did the MRI scan And let me tell you, this was a Friday afternoon at 4 p.m. So they scanned him. They didn't have a report. It takes a long time to get the neuroradiologist report. I had a look at this scan. Let me show you some slices. So we're coming down, coming down, coming down. I'll go up and down a few times, don't worry. The only thing I could see as I went up and down was there was clearly this abnormality here in the maxillary sinus on the left, which I couldn't identify or explain. And I wondered, is there something there which is compressing the trigeminal nerve? It's bright white. Otherwise, I wasn't sure I could see anything at all. So what I actually did to the patient said, I'm really sorry, we won't have your MRI scan results until Monday now. I gave him some amitriptyline, just 10 milligrams to take home for the weekend, because he said this horrible burning electrical pain was really distressing, to try and help with the symptoms. I said, come back on Monday. So he came back on Monday. I had a verbal report from radiology, a very preliminary one on the Friday, that said there is a large mucocele in the left maxillary antrum, but they said this shouldn't be causing any problem. This is a benign incidental finding. I gave him 25 amitriptyline and sent him home. So he came back on Monday, and on Monday I had the report, the MRI, and here we go. Although the appearances could be in keeping with demyelination, MS, the increased signal within the portion of the left trigeminal nerve would be unusual, and cerebral zoster, the cerebral zoster infection, should be considered, which was a big surprise to me because he had no vesicles, he had no signs of shingles at all. And he came back in on Monday. I met the patient. I brought the neurology doctor down to see him. And what they actually found here was a tiny bit of, this is what they're talking about. Can you see that little white thing just there in the pons? It was demyelination. His symptoms of this burning electrical pain had settled somewhat with amitriptyline, but he was still completely numb. We did a lumbar puncture then, which was normal for white cells and red blood cells. His protein level was elevated, his glucose was normal, and he had elevated oligoclonal bands in the serum and the CSF. And they made a diagnosis of a clinical isolated syndrome. What does this mean? You think about how you diagnose multiple sclerosis. To have that diagnosis, you need to have 2 episodes of demyelination separate in time and place. When you have your first episode of demyelination, therefore, they don't call it MS, they call it a clinically isolated syndrome. You need to fulfill the McDonald criteria for MS. So here is where my guy was. He had 1 attack, and the MRI had shown 1 lesion, that little bit of inflammation in the pons. So he said to get a diagnosis of MS, what he needed was a second attack, either await a second attack or repeat the MRI in a few months and see if any new lesions had appeared, which hadn't quite caused symptoms yet. So clinically isolated syndrome. Now, what does that mean, and how do you explain that to a patient? We know that 57% of patients with a clinically isolated syndrome develop MS within 2 years after their first episode. We know that patients with a monofocal, i.e. 1 single area, like my patient had, 20% of them go on to develop clinically definite MS. So it is still possible just to have that 1 episode of demyelination, but then never have another one ever again. And that's something that needs to be explained to patients when they're thinking about what their prognosis might be. If someone first presents with a polyfocal, clinically isolated episode, i.e. they've got 2 areas, 60 to 80% of them go on to develop clinically definite MS. So it's much more likely. And we tend to do sequential MRIs to follow up these patients rather than just waiting for them to develop symptoms, develop a second attack in order to make this diagnosis. Okay, that was my last case. So hopefully you guys found something useful there. If not, then hopefully you just enjoyed a little diversion from your usual day. Yes, maybe you've heard of some of those conditions before. Maybe they've been brand new to you, but either way, I hope you have found it to be a useful educational experience. If anyone has any questions, we're right on 3 o'clock now. Please do pop them in the chat. Otherwise, we'll close down for the day.